Yes.
Yeah.
Thank you. Okay, so your maternal history is this lady was a transfer of care from St George's at 29 weeks, had very limited English and she spoke Urdu, had language line available at all of her appointments, which was ideal, and in her care and labour as well. Medical history is that she's got a BMI of 29, but otherwise all completely normal. At St George's, they do something called an Aspray test, which basically gives you a presumption of any kind of preeclampsia or risk of SGA. And at 28, I had 28-week scan at St George's, she was confirmed as having SGA. She transferred over to us at around sort of 29 weeks, so about a week later. So we repeated her scan at 34 weeks. Estimated fetal weight was 2210, cephalic, placenta posterior height, and amniotic fluid and Dopplers were completely normal. On our gap charts, this baby was not showing up as SGA as according to this growth scan. So she was then sort of treated as lower risk from then on. 38 plus 3, she came to triage because the antenatal clinic midwife couldn't locate the fetal heart rate. But when she came into triage, it was absolutely fine. But they recommended induction of labour at 40-40. At 39 plus 1, she came into triage with query SHRUM, which was confirmed. She attended triage. Baby was oblique on ultrasound. So she was admitted for monitoring and an ultrasound in the morning before commencing induction. Basically, I think because she was sort of identified early on in pregnancy as being high risk. But then, yeah. So this was out on the 8th of the month at 1800. She SHRUM, so she was admitted to labour ward for observation overnight. No contractions at present, nothing palpated. She was feeling baby move well, no major concerns other than the SHRUM and the fact that the baby was oblique. So I think the plan was kind of see how she is in the morning, see if the baby's become more engaged with the lack of waters, and then try and start the induction process off. As you can see, OBS normal, blood pressure 123 over 82, pulse of 84, resps of 17, and a temperature of 36.9. And this Dawes-Redman criteria met at 30 minutes. Baseline is 140. Nice accelerations, and obviously no decels that we can see here either, with good variability. This was the following morning on the 9th at 7 o'clock. Criteria met at 50 minutes, despite that decel that you can see at around sort of 7:26. At 9 o'clock in the morning, the doctors did a review, and the plan was to start induction when she became prom, so at 24 hours, but to monitor her regularly throughout the day. Blood pressure 127/73, pulse of 92, temperature of 36.5, and a respiration rate of 18. Any questions at all?
Is she still oblique?
No, cephalic.
Okay, thank you.
Cool. So 1750, this is her CTG pre-prostin. Note how her pulse has sort of increased from what it was earlier. She's still got good fetal movements. She's no PV bleed. SHRUM's all completely clear like, and there's been sort of no concerns throughout the day. Respiration rate 18 and temperature of 36.4. We can see that our baseline sort of reduced down a little bit, but nothing that we would sort of have as a cause for concern really. But yeah, this was your sort of pre-prostin trace. And then this is your post-prostin trace. So 2 milligrams administered at 7 p.m. and her Bishop score was 2. Blood pressure 123 over 88, pulse has gone up to 100, respiration rate of 17 and a temperature of 36.4. Any questions, any worries? Okay, we'll move on. So this was a little bit later on in the evening. She's obviously now prom. She was examined at 00:10, which was essentially 6 hours post-prostin. Cervix actually couldn't be reached. The head was very ballotable. So the plan was to await events. The woman was tightening at this point. The CTG was shown to the obstetric reg in view of the decel, but advised to continue monitoring for an hour and discontinue if after an hour it's normal. Anyone agree or disagree with the plan?
With a blottable head, what are they say await events? So are we just waiting for her to contract more and hope that that head comes down a bit more engaged, or are we thinking Sinto or?
I think, yeah. The only thing that sort of concerns me is the midwife that sort of did this examination was actually very, very senior. Um, and the fact that this cervix is so posterior, it can't be reached. It just sort of makes me think, okay, how engaged was this head before we'd even started the process of induction? And although we'd confirmed via the scan that the baby was cephalic in the morning, actually prior to the administration of Prostin, like no ultrasound was performed just to confirm it. Um, and there's not really any record of any abdominal palpation either until it gets to sort of midnight. So just as a sort of side note here, if we're concerned about a baby's head that's very blottable, or if we're concerned about the fact that, you know, this baby's head's not very engaged, we are risking sort of cord prolapse. She's already schrom, so there's clearly still some waters that are sort of surrounding the fetal head if it's not sort of come down. So actually, this is the sort of person that we need to keep quite a close eye on. Specifically, although we've kind of said that this baby's not SGA with the Croydon scans, you know, at St George's, they'd said that she was very high risk, and they'd put it in a very different centile than the one that we had. We are seeing some sort of very variable D cells and whatnot. So nothing that's sort of outwardly concerning at this point. You know, we've still got good accelerations, we've still got good variability, and the baseline has remained stable throughout. But, you know, await events, it's a difficult one to sort of think about. This was the CTG that continued. So we're now, sorry guys, we're now on the 10th, yeah, the 10th of the month. Blood pressure is 116/81, pulse of 93, respiration rate of 18, and a temperature of 36.8. So this was discontinued as it had been an hour as per the obstetric plan. And the CTG was normal despite that one singular variable deceleration. At 03:45, this woman reported some abdominal pain. So dihydrocodeine was given, and it appeared to be working quite effectively for her. And then at 04:30, some bloods were taken, obviously with consent. I think this was due to the fact that she hadn't had any from admission. And obviously, when we do inductions of labour, we do tend to take an initial sort of set of bloods as per our protocol, really. Maternal pulse sort of sat in the 90 to 100 bracket, sometimes going over it, but she was obviously in a little bit of pain at this point. So 05:20, the dihydrocodeine's not worked as effectively as we would have liked it to. At this point, the midwives on our antenatal ward have requested a transfer due to maternal discomfort. The midwife in charge requested that due to activity, the case midwife that's on our antenatal ward needed to come with her. But unfortunately, because of the situation going on our antenatal ward, it was unsafe to leave one midwife alone with the women that were still there. So due to that fact, she remained on Hope Ward, and she was monitored on our antenatal ward.
Cara, I thought she started off on labour ward. So once we confirmed cephalic, was she moved then to the antenatal ward?
So she was never put on labour ward to start with, Indra.
Oh.
So she was seen in triage. She was moved straight to antenatal ward, and she was actually scanned over there, and then the induction was started over there as well.
Oh, okay. Sorry.
Yeah. So she's still on Hope Ward at the moment.
Okay.
Again, seeing some variable D cells here as well, but baseline still remains stable. We have still got accelerations, although variability looks a little bit more reduced than it has done previously, but we never know. This could be very much cycling, and obviously accelerations are very much a reassuring factor. This is continued. The position of this woman is changed to left lateral, and the concerns with those variable D cells was escalated to the obstetric registrar. Specifically at around sort of 06:45, as you can see there, quite a slightly longer deceleration that, you know, doesn't return to baseline for a good sort of 2 minutes or so. And so at 06:58, she was then transferred over to labour ward for CTG concerns. She's now on labour ward due to baroreceptor decelerations. At 07:22, another ultrasound was performed, and the position was confirmed as cephalic and head low. It's not documented anywhere exactly how low and whatnot from what I can see on our records. But that's obviously reassuring that the contractions that she has been having have hopefully brought that baby down sort of much more into the pelvis. Blood pressure 130/70, pulse of 99, respiratory of 18, and a temperature of 37.2. And our blood results came back at this point and were reviewed. HB of 115, platelets of 223, and a white cell count of 12.5 with a CRP of 15. So obviously slightly on the raise. Anyone want to be aware of anything in particular here?
Temperature is 37.2, raised CRP. Pulse, she's slightly tachy, but she's been tachy all along. I mean, she is high risk of having an infection because she's from raised CRP. Is the tachy showing signs that she's going to be, having an infection? So probably keeping a close eye, maybe do a septic screen.
Yeah.
Culture. Keep a really close eye on that temperature as well, and maybe baseline.
The good thing that something that I just want to sort of clarify that we don't really talk about a lot. When we talk about the difference between sort of chorio and infection, obviously with chorioamnionitis we normally see changes in the CTG from the baby's perspective before we see any sort of signs in the mother. And although she has been tachycardic for quite a long period of time, bearing in mind like previously her heart rate was around the 80s, and her temperature is on the rise. We're not quite over that borderline of obviously, oh, we need to do a full septic screen just yet. But if you're using your clinical judgment, what's going on in the room, what's the woman feeling, looking at the overall clinical picture here, prom now, 36 hours, I think. Yeah, 36 hours we're at prom now. Things, maybe we would hold off for a little bit longer, but also at the same time, if you make that decision to do it beforehand, then you're not causing any harm, essentially. So we'll continue. So there's a VE done by the doctor at 07:45 and the cervix is fingertip dilated. At 08:12, she's turned to left lateral after that variable deceleration that you can see there. Baseline still remains sort of 130 with some accelerations present, and the toco is not really picking anything up, but also she's feeling some tightenings, but not sort of full-blown strong contractions at this point. So 8:30, we've got a handover to our day midwife. Blood pressure is 119/86, pulse of 108, respiratory of 18, and a temperature of 37.2. The decision was made to start oxytocin, obviously because of slow progress, the fact that she's prom, and the fact that there's no contractions really picking up at present. So at 09:03, Synto was started on 3 meals as per our protocol. Anyone agree or disagree with that plan?
I think I agree. It is acceptable. Yeah.
Perfect. Me too. Blood pressure is repeated, 132/85, pulse of 101, respiratory of 17, temperature of 36.6. And the Synto is increased as it would normally be. She was started contracting quite quickly, so the Synto worked quite effectively, quite quickly, and they became quite strong on palpation as well. And the Toco's picking them up really well here as well. So we continue. Pulse still remains slightly tacky at 105. I don't think any fluids were started, just to see if this pulse was due to maternal dehydration. But we'll continue. We keep going for quite a while, so she's picked up to around 4 in 10 now, which is great. Synto's still running, I believe, at 6 mils an hour, so it's having a really good effect, which is great. Goes out to toilet at 11:38. Blood pressure is 124/79, pulse of 103, resps of 17, and temperature of 36.6. Still got accelerations present on the CTG. Baseline's still lovely and stable. Variability is a little bit reduced, but we're not concerned about it at this point. We keep going. Clients are vomiting at around 12:17. They didn't record the amount of mils, but possibly just sort of pain related. Some areas she's contracting sort of 5 in 10, but baby seems to be compensating really well with that, coping very well. Also, she's moved to a semi-recumbent position at 12:38. I'm assuming that's due to sort of maternal comfort as opposed to anything else. But we keep going. Pulse is now 109. She's still contracting well. Respiration rates increase a little bit to 19. Blood pressure is still stable, and her temperature's actually come down. At 13:53, she is examined and she's found to be 2 centimeters dilated. And at this point, she's requesting to have an epidural sited. Baseline's still the same. No any big changes in the CTG. At 14:27, IV Hartmann's is started. And at 14:30, she's moved into a left lateral position for epidural because they're really struggling to get the fetal heart rate picking up on the CTG. This is obviously this actually room was on the central monitoring system as well. So this was being observed by, well, anybody else that was present on labour ward that was near it. Not the best example of fetal monitoring during an epidural. I'm not sure if this was due to maternal position and whatnot, but just as an essential, I mentioned this very, very regularly, that actually it's really, really important that we make sure we've got fetal monitoring during an epidural because we know it can have an impact on our baby. So please, as a side note, make sure that actually you're ensuring fetal heart rate is there and is picking up well before the process of an epidural is started. That's as an essential. At 14:50, the obstetric registrar actually comes into the room because she notices that obviously there's quite a lot of loss of contact on the CTG. This midwife I've encouraged to have asked for some support with this if this was the case. The registrar puts on an FSE, but unfortunately it wasn't working very well. And at this point it was said, okay, we need to press pause for a minute. We need to move her into a different position so that we can pick up the fetal heart rate a lot better. So at 15:01, she's moved to right lateral position, and as you can see, it's picked up quite nicely. At
Can
15,
I say something? Sorry, Cara.
push
You know
cam.
what? At other hospitals, epidural, they tend to do it on the, on the side when it's left lateral, and you're able to monitor the baby. Since we've been in Crohn, we always try and sit the women, especially women as a bit raised BMI. It's very difficult unless you've got an FSC to monitor this baby. So I'm wondering why ornithis never, I don't think they like to do it on the like left lateral or right lateral position.
I think
Maybe
it's
something. I don't know.
I think it's a culture thing as well. I really do. You know how go on.
No, I don't think, Cara, is cultural or anything. And the answer to that is simple. On sitting, you are opening the vertebral spaces easier than on the left lateral. So if I am the anesthetist doing it, the arching of the back and more arching, even sometimes they ask for more arching of the back, opens more the intervertebral spaces to insert whatever they want to insert. Left lateral, the crunching of the like the knee chest position is not the easiest. And unless the anesthetist is really, really comfortable with the position, will be similar to us as obstetrician delivering in all four. So it is not a position that they are comfortable doing the epidural in.
So even if the women are kind of curl up with the knee chest position, it's still a bit more difficult.
It is, yes, it is.
Okay.
Yeah, you need a very, very experienced anesthetist to do it in this position. So the reason is many times I see people, even spinal, they really sometimes struggle doing it on this position.
Do you know what would be really interesting though is if we were to do an audit and see, you know, I've read, I don't quote me on this because I don't know where I read this, but there's actually some research to suggest that you've got less opportunity for fetal bradycardia post-spinal if you do the spinal in a left lateral position as opposed to being sat upright and then moving down into like a semi-recumbent or a completely flat position. So it would be interesting to see if that would have an impact on like fetal well-being, because you know we've all been there when we've been in theatre, spinal's gone in, we've listened to the fetal heart rate, and something that could have been a lot more calm has actually turned into more of an emergency because of a fetal deceleration. So it would be interesting. We wouldn't really have much to go by because obviously we don't do any spinals in a left lateral position, but I wonder if maybe we could have that conversation with some of our anaesthetists.
It's funny because
so even
I think putting FSC would be the best option. But some of these FSCs are not compatible with the CTGs. I think the only FSC that works is the long ones.
So they're all
trying to balance it
compatible.
really.
They're all compatible with our monitors.
Obviously, if there's such a long time for loss of contact, then we should really advise FSC.
Yeah, absolutely. So
to monitor the baby properly.
Meats are not dilated, then you know we've lost that option of putting an FSC. Certainly, if it's dilated, yes, we should try an FSC.
Yeah, absolutely. Just to sort of clarify, all of the FSCs that we have are compatible with our machines. It's just a case of, I mean, we've got two different ones at the moment because we're trialing some from a different company, which are the long ones, which are some people prefer them, some people hate them. Everyone's got their preferences and whatnot, but yeah, there's the element of human error when it comes to sort of putting them on and whatnot, which is obviously also contributes to the amount of loss of contact that you get on these.
Yeah, so to answer you, Cara, about the audit and asking anesthetists and whether left lateral is better than sitting, it is anatomically, yes, it is better for the baby. No single doubt. We are not saying so, but it is a like if you want to resuscitate a person on the street, and you are resuscitating on his back or her back, or resuscitating on the side, and so on. It is a something that you are more comfortable to do and more easier to do. Like if you want me to do a cesarean section on a lady that is on her side, yes, I will do, but it will be extremely difficult. So it is a comfort. It is what I am used to do, and what I am comfortable to do, and what is the quickest thing to do in a situation.
Yeah, absolutely. But I would be really interested to see the audit results from that. That's for sure.
I think there's an element of culture as well, you know, because when I was at Kingston, all epidural started off on the sides. And if it's very, very difficult, then it goes, you know, we change position to sitting.
Yeah. Yeah,
So
possibly. I think
interesting, yeah.
there's lots of obviously contributing factors. Mr. Naguib, I'm pretty sure you could probably do a cesarean section upside down as well if you wanted to, but yeah.
Yes, but what I want to say is I worked in Kingston as well, Indra, for a long time, and as well as nearly 15 hospitals. The preferable position of spinal or epidural is sitting. And
Yeah.
even with sitting, especially with very high BMI, it is
Yeah.
very, very, very challenging because you can they are palpating the intervertebral space, and to palpate it in a big lady, it is not easy. So yeah, so I personally, what we can control obstetrically is two things. One is to bring the ODP to assist the anesthetist. The second thing is to put an FSE. We cannot control the factor of what is the position of the anesthetist will do, because even when you call a Cat 1, you cannot control what the anesthetist wants to do in most of the time. If they say, I will do spinal, not GA, because I'm not comfortable, my hands are tied as
Yeah.
obstetrician. So what we can control and we can really encourage all our staff to do is an FSE, yes, and asking him or her to bring the ODP with them, so the midwife can do the monitoring. That's all. Yeah.
I think that's really good, because the midwife tries to get the stuff ready for the anesthetist and try to monitor the baby at the same time. So where they can keep their hand on the monitoring, they're actually helping the anesthetist. So if you've got the ODP in the room, which I think they're quite linked to labor ward, then that would be probably one of the big help, really.
Indra, this is one of the conversations I have on probably a weekly basis. I've spoken to everybody that needs to be spoken about this, and it's kind of in cahoots at the moment, but the ODP's contract doesn't include labour ward, it's obstetric theatre. So it's not the responsibility of the midwife, you're absolutely right, and our priority should be fetal monitoring. But what we need to be doing is maybe, as obviously asking for the ODPs if possible, but if we can't get another ODP, get a second midwife. So for this, for example, we've got an obstetric reg that's actually come in to help in this case. Like anybody can come in to assist. So if you're the case midwife and you need to help the anaesthetist because they don't have an ODP or something like that, then that's fine. But you need to have somebody that's definitely got good contact in the meantime. And at the end of the day, some babies are good as gold when they're having an epidural sited, and we don't have any loss of contact. But obviously, when that's not the case, we need to do something about it. But it has been brought up anyway.
Thank you.
So she's actually was then given a spinal because she was having quite a lot of pain with the epidural process. So once the spinal was in, the anaesthetist then cited the epidural and gave the test dose at 1532. Blood pressure is 110/53 and pulse now 119. So she's definitely tachycardic now. And also, anybody notice anything else about this CTG?
It's a rise in baseline now, isn't it?
Yeah. So our baseline's pretty much been sat at 140 the whole way through. It's now gone up to 150. So we're not going to be like overly concerned at this point because we want it to sort of be about a 10% increase, but it's just worth noting. Also, the fact that mum's pulse has now gone well above 100 is an also factor, but bearing in mind she's been in pain, we'd just give it a little while and then maybe wait and see if it does come back down again. At 16:05, her blood pressure was 115/56, pulse of 118 and temperature of 36.7, respiration rate of 16, and the Synto was increased at this point to 12 mils per hour. At 16:30, her pulse is increased to 131. So this woman is increasingly getting worse and worse tachycardia. So at 16:36, the midwife notes the fact that the maternal pulse is 131 and the fetus is now about 165 towards the end of this, and does escalate this. Escalates it at 16:40. At 16:42, an indwelling catheter is inserted, and at this point, mum's pulse went up to 170. the Synto is then increased to 24 mils per hour. I forgot to mention, sorry, the line that you see through the CTG on this one, so around 1609, was a consultant review who had advised the midwife to increase the Synto back up again. So Synto was increased to 12.
Sorry, Cara. Yeah, sorry, Cara. Now the pulse is
118 when the consultant was present.
Right, and advice is to increase to 12.
Yeah.
Okay, fine. So just to clarify, yeah.
Yeah, so the plan was to increase to 12, which the midwife did. The midwife then notes that there is maternal and fetal tachycardia, so escalates it to the registrar, who is unfortunately busy in theatre with a different case at this point. So she inserts an indwelling catheter, notices that mum's pulses are also now up to 170, increases the Synto again to 24 mils an hour as per the sort of guideline of increasing Synto.
Sorry, again, Cara, did she escalate? Because 118, I understand. 170 now, did she escalate before putting it up to 170? Before, I mean, after the pulse is 170?
So it'd been escalated at 1640 that the maternal pulse was 170, but there wasn't a review before she then increased the Synto to 24 mils an hour.
Right, okay.
And then
Right.
it wasn't until about 40 minutes later that an obstetric SHO came to review, said, I need to speak with the registrar, but I think we should do a septic screen, due to the fact we've now got maternal pulse that's very high and fetal tachycardia of up
Okay.
to about 100 and also about 170.
And the obstetric SHO reviewed and wanted to discuss and say septic screen without, again, escalating to the reg or the consultant that is 170 now.
So the SHO came to review and then went immediately to the reg.
Okay, all right, okay, fine.
At 17:35, the bloods were taken, but the registrar is still in theatre at this point. The reg comes to review at 17:53. Plan is still still to do the full septic screen. But I think this woman, from what I can gather from Cerner, this woman is very difficult to bleed. So a lot of focus in this case was based on trying to get bloods as opposed to actually trying to treat. We all know that we take the bloods for a septic screen prior to treating with antibiotics and giving IV paracetamol. However, this was the time to escalate and ask for support in this case, because actually we've now got to a point where we're an hour later and we've still not treated this woman for possible sepsis.
Agree.
At 1800 as well, she's now prom for 48 hours. So plan was from one specific person was to increase Synto. Synto was increased. Tachycardia on both maternal and fetal was obviously very obvious. Was escalated to an SHO, was then escalated to an obstetric registrar who didn't have the capacity to review until they were out of theatre. The plan was for a septic screen, but unfortunately we didn't treat this woman in our sepsis 6 golden hour, essentially.
Was the consultant in theatre as well?
No, I don't believe so.
So we could have utilised a consultant to review.
Yeah, I mean, I would imagine if the SHO if the consultant was present, the SHO would have obviously asked the consultant, but I don't know if they were present at the time on labour ward to speak to.
So where was the coordinator in all this?
That's a very good question. It's not really documented, and I don't think the coordinator was present for this midwife either.
Okay, yeah.
So just talking about our escalation and whatnot, if we need help with something, we always need to ask for it. This is just something that I really wanted to highlight with this case, is the importance of escalation. I've had individual chats with the person that was looking after this woman. It was I think it was quite a busy day on labour ward at the time. So unfortunately things did get delayed, but also just asking your peers. It doesn't always have to be the midwife in charge. We can ask any of the specialists, any of the other leads around the areas to come and help if we can't get access to anybody else, if everyone else came for a one-to-one, for example, and whatnot. It's always good to always ask for help, because even though people want to do things themselves, it's actually more important that we provide the perfect care and the best care we can for these women.
And also, Cara,
Yeah,
not only asking, and if you asked and you can't get, document.
absolutely. Absolutely. Really, really important. Okay. The registrar comes to review again at 1825. Our baseline is now 180. And she was examined. This woman still remains 2 centimetres dilated. So the decision was made for a category 2 emergency cesarean section, and she was consented 15 minutes later. The bloods had come back, HB 112, platelets 227, white cell count had actually increased to 18.6 from 12.5, and unfortunately the CRP wasn't taken. So sepsis is one of those things that we are working as a risk and education team to really combat at the moment. We're doing a lot of work to try and improve our care for women that are at risk of sepsis. And this is one of our sort of good examples of cases where we also need to learn how to escalate better. I'm doing some work with the, what's it called, Each Baby Counts program to try and introduce that, and hopefully our escalation policy will become a lot better with that as well. So a lot of things, a lot of learning points from this case that are being addressed. So yeah, just watch this space essentially. So anybody want to guess the APGARs and the gases? Do we have a theatre? Yeah, we have a theatre CTG. 1850 went into theatre and baby was delivered 17 minutes later.
I think, again, it is a case of sepsis. So it is a kind of, the gases will not be like so awful, 7.1, 7.2. It is mainly the baby is going to struggle in sepsis, really.
Yeah. Anybody else?
Yeah, I think so as well. Was Mom ever given antibiotics at all, Cara?
Not till she was in theatre.
When
And
she
if
was
you
in
look
theatre.
at this CTG, if it's kind of hidden, look at where you might be able to see the baseline here.
But 200, isn't it?
Yeah.
Mm. Yeah, the alcohol would be fine because of sepsis, but
And
baby,
it is sepsis on the background of, if I remember well from the beginning of the case, it is a small for gestational age or something from St. George's. So
Yeah.
we are talking about a tiny baby that also might not be able to cope. So yeah.
Absolutely. Okay. Baby was born with APGARs of 8, 10, 10. Baby was 3 to 25 grams on the 30th centile. arterial pH of 7.17, base excess of -7, and a lactate of 7.5. Venous pH of 7.23, base excess of -5, and a lactate of 6.1. Baby had risk factor, obviously, of sepsis, so was screened and treated. Temperature for baby at delivery was 37.6. When this baby, about an hour old, went round to Skaboo to have a cannula sited and some bloods taken, or repeat gases, essentially, BM was actually 1.4, and the lactate was 7.6. So this baby actually ended up sadly being admitted to Skaboo, and was very much treated for infection. Blood cultures came back negative, but there was definitely some kind of impact from this mother's condition on this baby. Any questions?
No questions, really. It is emphasis on more prompt action rather than waiting till we get the full-blown picture, really. It is, I can't say that the management is wrong, but at the same time, we cannot wait till the end, really, and act.
Yes.
Which we tend to do most of the time.
Absolutely. I think there's a few really good learning points from this one, and I hope that we can learn from it. And just as a sort of, key message, please, if you're ever concerned about anything, escalate immediately. And if you ever need some support, then find someone, essentially. But yeah, anybody have any other questions? If not, that's all
Sorry,
done.
Cara, when the maternal pulse was 170, I guess that should have been escalated, isn't it?
Yeah.
I do not know if she had any fluids right from the beginning, and she had a spinal as well. And to include this into on top.
Fluids were started when she had her epidural or her spinal sighted just before. So she had a litre of Hartmann's running all throughout that.
Yeah, because that's a bit of a worry with 170 of maternal pulse.
Thank you so much, Cara. It is a very enlightening and very educating as well. Thank you.
You're welcome. Perfect. I'll see you guys all next week.
Thank you.
Thank you.
Thank you so much.
Thank you.